Hey folks, welcome to another episode of Bundle of Rays, and this week we're talking about renal physiology. Renal physiology can be a complicated thing, and as a nurse I totally understand that. I've spent a long time just confused. Generally just not understanding. So let's have a look at what renal physiology is, how it works, how we get blood there, how it filters, and if you've got any questions after the video, please feel free to contact us and we can talk through them. All right, good luck, and I'm sure we'll talk to you soon. Hi folks, welcome back to another week of Bundle of Rays. So this week we're having a look at renal physiology. Now I know during my career I've done a bit of intensive care, I've done some primary health, metabolic understanding and working through functions of the kidneys really isn't something we don't touch base with a lot. So I find a lot of value getting this ready for you, and I hope you get some value out of it as well. So let's go in and have a look at these two bean-shaped organs here. Now, essentially, these little guys are busy. They excrete a lot of metabolic waste, they regulate fluid, and they help us balance electrolytes along with promoting bone integrity. So, you know, vital functions for our body, and they're very sensitive in relation to our cardiovascular system and our ability to maintain hemodynamic stability. So whenever we're looking at the kidneys, so sitting posteriorly here, we always want to make sure we're thinking about renal blood flow and how that's going to affect the ability for the kidneys to filter, which is the glomerular filtration rate. For some reason I can't spit that out today. But we need to make sure that there's a delicate balance between that blood flow and the filtration rate in order to maintain homeostasis. So an important function and interplay between blood flow and the kidneys is the renin-angiotensin system, which I'm sure we've all come across at some point. But do we really understand it on a day-to-day basis and how that impacts us at the bedside? So it's the ability to release renin and then go about managing our blood pressure with the conversion of angiotensin 1 to angiotensin 2 in the lungs. Now, the simultaneous effects that occur are to create a gradient for soda and water reabsorption, and there's multiple ways that happens, which we cover a little bit later on, but these are the type of things that we should be thinking about. So once we go into the kidney here and have a look at the different structures, we've got the renal pyramids and the medulla. Once we go in a little closer, we'll see the Bowman's capsule. We realize that this is a very unique organ, and there's a lot of passive processes at play, in particular related to hydrostatic pressure. So the pressure in relation to the renal artery and the renal vein is vital in order to understand how we move fluid through and then extract either water or solutes out of that as they go through the renal nephrons. Now, total renal blood flow is around 20% of our total cardiac output. So when we're having a look at somebody who might be in something like cardiogenic shock, usually it's the kidneys that are going to go first because they do rely on a large amount of that cardiac output in order to have good end organ function. Now, on top of that, as we have a look at the blood flow there, you can see it goes out to the renal pyramids. We're looking at an ability to maintain a GFR, so the glomerular filtration rate, which is determined by a Starling equation, which is the filtration coefficient multiplied by the difference between the glomerular capillary oncotic pressure and the Bowman's capsule oncotic pressure, subtracted by the glomerular capillary hydrostatic pressure. Right, did you get all that? Now, the reality is that when we send our bloods off at work, we get a GFR calculated for us. Now, I think it's important to make sure that from a very basic level is that we know what those GFR numbers are, and we understand that if they're presented to us as percentages, then if we have a GFR of 20, we realize that that is a very significant impact to end organ function. Okay, so if we're just going to change scene here, now, if we're thinking about pathophysiology, we can start to talk about pre-renal damage to the kidney. So if the kidneys are insulted and there is a low blood circulating volume, they can have a pre-renal damage. So pre-renal meaning that the damage is occurring before the kidney, which is in relation to the fact that there's a less lack of volume, and therefore they're not getting the perfusion that they require. Intrarenal can be related to sort of cystic damage. Polycystic kidney is a good example. So I'm just pulling the kidney apart here. But the renal cortex, as you can see there, so if you had a polycystic intrarenal disease process occurring, it would occur inside the center of the kidney here, and that would be a intrarenal, and then you have post-renal damage, which can come from something like a urinary infection, and urinary infection being a cause of an obstruction to the outflow tract of the kidneys once they've collected fluid and looking to move it out. So there's just a cadaveric image there to have a look at the veins and arteries that surround the kidney. So just a brief discussion on pre-renal, intrarenal and post-renal, while we have a look at some of the renal internal anatomy. Now, you know, the complexities of the metabolic demands of the kidneys is vital to understand, because if we have a high amount of blood flow, we also have a decreased amount of oxygen extraction. Now, when you sort of compute that in your head, you think, well, if there's a lot of blood going there, there's a lot of oxygen going there, but the kidneys don't have a high metabolic demand. Okay, they need the blood flow because they need that amount of fluid going towards the organ to do the filtration. So they have a high amount of blood flow, but they have a low oxygen extraction out of that flow that comes to them, because they don't have a high metabolic demand. The demand is for the flow, so they can filter. Now, they do balance blood pressure through something called autoregulation. Now, that's the ability to keep the GFR constant despite the blood pressure, in order to make sure that water and electrolyte maintenance is also constant. And we'll get into that a little bit later. Okay, so let's just have a quick look at a bit of terminology. So the glomerular filtration is the initial process in urine production. So this is a passive process in which hydrostatic pressure pushes fluid and solute through a membrane with no energy requirement. Now, feel free to pause the video on these slides if you need to read the content. And a normal GFR is between 120 to 125 mils per minute. Now, just like magic, we're talking a little bit before about autoregulation and the ability for the kidney to maintain blood pressure. Here's three components of the renin-angiotensin system outlined about how renin has its effect. I could read them out, but you'll get bored of my voice, I'm sure of it. So just feel free to pause the videos. All right, and then tubular reabsorption. So there's a bit of details on this slide with apologies, but all important stuff. So effectively, this is talking about the four differing segments and how and when they absorb water, sodium, potassium, all the different electrolytes, things like aldosterone and parathyroid hormone. So lots to learn in relation to renal function. So acute kidney injury was previously called acute renal failure, and generally we measure this looking at the glomerular filtration rate, which we've just discussed. So after an insult, the kidneys are going to have a decreased amount of filtration, and we're obviously able to measure that. So we're going to have possible complications such as an accumulation of water or sodium or other different metabolic products like phosphate, calcium, etc. Electrolyte disturbances, and it's one of the most common admissions. So it can be seen in up to 7% of admissions and 30% of intensive care admissions. Now, in order to understand some of this, we mentioned earlier about pre-renal, intrarenal or intrinsic renal, and post-renal. So if we think about pre-renal, it's probably a lot of the instances that we do see in a sort of deteriorating patient scenario. So if you think about things like hypovolemia, hemorrhage, gastrointestinal fluid loss like diarrhea or vomiting, You can have straight hypertension in relation to a decreased cardiac output, big PE or acute coronary syndrome. Other forms of hypertension through sort of septic shock or anaphylaxis, and renal constriction, so vasoconstriction to the renal area by iodine, so during our contrast scans, and also thinking about NSAIDs. And another area is with the ACE inhibitors in terms of impacting glomerular effluent arterial vasodilation. So 5 real key points in relation to renal blood flow that can affect the pre-renal form of an AKI. Now, as mentioned, the intrinsic or intrarenal processes are things like cysts or interstitial nephritis because of drugs like penicillins or something like that. And then looking at the post causes, mainly due to obstruction. So it could be calculi or clots, and otherwise infection through the outflow tract. So from a clinical significance perspective, we've talked a little bit about tubular reabsorption earlier on our slides. Just want to discuss that a little bit at length here. So if we're looking at changes in the dynamics around the glomerulus, it's important factors as a nurse at the bedside to take on board. For example, we can impact the function of prostaglandins, which cause the afferent arteriole in the kidney to dilate. So when we give drugs such as NSAIDs, so ibuprofen, etc., are administered, these change the glomerulus to be expected because NSAIDs reduce the formation of prostaglandins. Now, understanding the pharmacological impact of our drugs on a daily basis is a huge thing. Now, I know, hand up straight away when I was a new grad, I was just given drugs. I was just reading how to give them, and I just wanted to make sure that I was giving them safely. But now, you know, once you're in practice and you need to start to unravel the metabolic and absorption and the pharmacokinetics and pharmacodynamics of your medicines, that these are really key things to understand. And NSAIDs in the kidneys are a great example of what they can do and how we should understand them. So in a patient exhibiting signs and symptoms of kidney disease, we need to be very cautious if any of our patients get some ketorolac or they're on ibuprofen, for whatever reason, that we should be monitoring their renal function and understanding how we monitor their renal function. So through a GFR and looking at urine output and those type of features. So if we just go back to the anatomy and we start to think about this nephron with our different tubules here, we understand that once this blood flow comes through and we start to move solutes and electrolytes, the ability for us to do that is really dependent on the amount of fluid that we have. So having our sodium monitored regularly, monitoring our potassium regularly, and because, you know, in the distal tubule, the parathyroid hormone influences calcium. So calcium is also going to be something that we're going to watch. And the other thing is phosphate. So hyperphosphatemia or hypophosphatemia are areas within renal function that through these tubules at different areas, different pressures and different flow, all get mediated due to varying hydrostatic pressures, which as a nurse at the bedside is vitally important, particularly if you're thinking about a deteriorating patient or someone who might have chronic renal disease and is having an acute crisis, so an acute on chronic scenario, which, you know, if you're an emergency nurse, that can be quite a challenging thing to have a specialty flare-up such as that. Okay, there we have it, renal physiology. So we had a good look at renal blood flow, we talked about glomerular filtration rates, and had a very quick overview in relation to tubular absorption, from having a look at nephrons and going inside tubules, to a brief discussion around how we monitor and manage our water and sodium and electrolytes, aldosterone, renin, etc. So I hope you enjoyed it. You take care, you stay safe out there. And I'm sure we'll see you soon.